Hello, my name is Rachel Haas, and I am a DMP student at Gonzaga University. I worked on the NBMI adolescent unit for over 4 years, and it was honestly one of the most profound experiences of my life. This DMP project is one way that I would like to see inpatient adolescent unit care improved, which is violence prevention and how we can manage violence. I am so grateful for all the work that was put into this project by NBMI management and staff members. NBMI is an incredible place to work, and one of the best parts is the creativity and collaboration and teamwork that happens, and how hard staff members are willing to work to improve patient care. One important thing to know about inpatient psychiatric violence is that inpatient psychiatric units have double the amount of violence compared to medical surgical units, and adolescent units have higher rates of violence compared to adult units. Throughout my studies as a DNP student, I have found that there is a deficit of research on how to provide best care in an inpatient psychiatric setting. But I have taken the evidence I have been able to find on how to prevent violence in the inpatient setting and used it to create the violence prevention protocol. I'd like to briefly share some of my research on inpatient psychiatric violence. For example, nurses and mental health technicians are the most common target of aggression. The research shows that there are patterns to how violent events occur and why. And patterns include patient characteristics, environmental factors, and staff behaviors, and also the time of day. Violent events are most commonly occurring during evening shifts. Seclusion and restraint are interventions that psychiatric staff members use to ensure safety, but they are absolutely something that hurts both staff and patient in a variety of ways. Patients and staff may experience moral, mental, emotional, and spiritual suffering when there is violence or use of seclusion and restraint. Violent events can lead to patient injury, and seclusion and restraint episodes in particular can lead to severe injuries and even patient death. It's worth being aware that violent events can trigger a patient to re-experience past trauma and trigger their PTSD symptoms. The literature reviews on violent events and seclusion and restraint episodes in various inpatient psychiatric units demonstrate that there is a significant variation in the frequency. And what this means is that there are things that we can do as a unit to decrease the amount in which violence occurs. A 16-year longitudinal study done in Greece on an inpatient psychiatric adolescent unit looked at the modifiable risk factors for violent events. And two big things I'd like to tell you is that for each patient who was admitted that had a history of violence, increased the overall risk of a violent event occurring by 14%. Yet, for each additional nurse that was present on the unit, decreased the violence risk by 60%. Violent events also affect staff members in the hospital as a whole. One study found that up to 40% of staff members had incurred some sort of injury from a violent event. Staff incur injuries like minor scrapes and bruises, broken bones, and severe head trauma. They can occur through direct patient assault or through implementing interventions like seclusion and restraint. One study found that up to 40% of staff members on an inpatient psychiatric unit had some PTSD symptoms related to violent events that occurred on the unit. Staff can suffer from violent events through a loss of confidence in their job, a decrease of morale and motivation. Units that have higher rates of seclusion and restraint episodes also have higher rates of staff turnover and sick days. Violent events also cost staff time. One study found that an hour-long restraint episode caused an additional 25 nursing tasks and up to 12 hours of additional staff time. Violent events are expensive. A study done in England inpatient psychiatric units in 2015 discovered that the average yearly cost for one inpatient psychiatric unit was $293,000, and that money was for seclusion and restraint episodes, additional staffing, and other one-to-one heightened protocols that required staff time and other hospital resources. I'm going to explain to you what the violence prevention protocol entails. There are a variety of resources and things that have been developed to facilitate inpatient staff members to use and carry out the protocol. There are 3 new documents that are going to be included in the adolescent admission in FormFast. So when you go to FormFast, you will see 3 documents that make up the violence prevention protocol. The first document is titled NBMI's Method for Managing Patient Safety, Information for Patients and Parents. And it is an explanation of how we deal with unsafe behaviors on the inpatient adolescent unit. And it is to inform patients and parents about what we do to support them, but also to give them a heads up. And so that way there's no surprises down the road. This document should help improve consistency in what patients and parents get in terms of communication, especially about seclusion and restraint episodes, use of IM medication, and other interventions, including safety plans, treatment team meetings, parent involvement. The second document is the HCR20, which is a violence risk assessment that you will complete with the patient on admission. The third document is an individualized emotional regulation plan, which should facilitate a conversation on how to best support the patient cope with difficult feelings while they're on the unit. The violence prevention protocol is not just 3 documents you fill out on admission. It's a way to improve how we understand and can prevent violence for our patients. The individualized emotional regulation plans are meant to be a tool for both patients and staff throughout their stay. And the aim is we have more consistent communication about why a patient may be a violence risk and how we can help de-escalate a patient in order to prevent violence. I have made some resources available for staff members in order to have confidence completing the HCR20 risk assessment scale. I have made a handout for staff, which should be emailed to you, and there will be additional copies available on the unit. Also, here is the handbook that explains question by question how to complete the HCR20. The violence prevention protocol is by no means done, and I'm hoping to attain feedback throughout this process to find out what works, what doesn't work, and what we can do better in the future to help prevent violence. This video talks about the first part of this protocol, which is a violence risk assessment. And the violence risk assessment I'm going to educate you all on so that you can do with patients is the HCR20. Here it is. And it stands for Historical Clinical Risk Assessment, and it consists of 20 questions. And per this protocol, this violence risk assessment scale is going to be done on admission. And that's the only time it's going to be done. And the aim is to get an objective sense of how a person may be a violence risk while they're on the unit. Children are not little adults. This scale is intended for both adolescents and adults, which means it imperfectly works for an inpatient adolescent unit. But I will explain how to best use the scale for adolescents. I will give you some background on how and why we should do a violence risk assessment. And I will go over some details about completing a violence risk assessment, this HCR20. In addition, attached to this video, you should be able to see a handout. There is a one-page brief version, and then there is a longer detailed version. Additionally, on the unit, there will be this entire handbook, which explains everything question by question and goes over all the detail and information, anything you may want to possibly know about the HCR20. So why do a violence risk assessment? We have a lot of assessments, and I am asking that the staff members who do adolescent admissions on NBMI do another assessment. The aim of this is that we can, number one, prevent violence by having some sort of objective measurement of violence risk. And secondly, a deficit we currently have is a language and a common way to understand and objectively measure violence risk on the unit. And this will give us more capacity to communicate with our peers, the chargers, providers, and even the house supervisor for how and why a patient is violent. Another thing that you can think about is we currently do risk assessments for fall risk and sepsis risk, but a big thing that happens that we do not objectively measure is violence risk. When administering a violence risk assessment or considering a person's violence risk, we are going to consider that complexity will haunt us throughout the violence risk assessment process by Stephen Hart, who is one of the founders of the HCR20. Violence risk is a complex process. It can be changing, and it can be something that people see as a label. And we're not trying to label our patients. We're trying to equip ourselves with better communication and therefore provide our baseline staff an ability to better manage potential violence risks. There are many risk assessments available for use. So why are we going to use the HCR20 on NBMI? It is a scale that's been around for a long time, over 25 years, and it's used in a variety of countries, over 20. And most importantly, there is strong inter-rater reliability, which means that two people can do a risk assessment and get similar scores. Another aspect that I think is super relevant, especially to adolescent psych, is it is determined on clinical judgment, which means the final score in terms of a person being a high, low, or medium violence risk is about the assessor's perception of the violence risk factors in the context that's in front of them. It uses the past, present, and future, and all the risk assessment questions are based on evidence. The scale is ultimately taking objective violence risk factors that are evidence-based, but then asking you as the clinical assessor to use your judgment to interpret and incorporate the context of the individual to determine what the patient's violence risk is. The HCR20 is far from perfect, especially when using it with adolescent patients. In terms of making this scale work for the patients here on the adolescent NBMI unit, me and Dr. Yates have created this version of the scale, in which you can see two questions are blacked out. The first is asking about other antisocial personality disorder traits and behaviors, and the second is, does the patient have a personality disorder? Now, both of those are grossly inappropriate for working with adolescent patients, because an adolescent is still developing their personality. Their frontal lobe and wiring and set of behaviors and who they're going to be is still under construction. Now, each section of the HCR20, the historical, clinical, and risk aspect, have a box that says other considerations. And so if a patient is engaging in personality-like behaviors, for example, fire setting, hurting animals, or deliberate self-harm that fits the pattern of type B personality traits, you may decide to list that in the other category. But it is never appropriate to label an adolescent patient as having a personality disorder. So the other thing about this scale is that it takes time. And I'm asking you to do another risk assessment, another form, during an already lengthy admission process. The hope is that it will save time further down the road when it comes to communicating and articulating accurately the needs and why a patient is a violence risk. And it'll hopefully save time in terms of managing violence risk patients by understanding what makes them a violence risk and how we can help them. The rest of this video is a detailed explanation of step-by-step on how to complete the HCR20 violence risk assessment. All the information I will be presenting here will be available on a handout that is in your email and will just be all over the NBMI adolescent unit. All right, real quick, here is the down and dirty about how to complete the HCR20 risk assessment. Here we go. We have this top part. Here you go. Make sure the patient's name is somewhere on the piece of paper. Number 2, you're going to go through and assess these different risk factors for 2 different categories. The first category is if the risk factors are present. And then the second, after you go through this, for all the risk factors, is to assess the relevance of each risk factor. And then down here at the bottom, you complete the risk assessment based on your clinical judgment of the situation. For if it's a future violence risk / need to prioritize the case. 2, if the patient is at risk for causing serious physical harm. And number 3, if the patient is at risk for causing imminent violence on the unit. And that is the basics of how to complete the HCR20 risk assessment. The other thing that you should really consider is that if a patient is a high or medium violence risk, what interventions do we have available for them? Now, this is addressed in the second part of the violence risk assessment protocol with the individualized emotional regulation plan. But also, it can be very important to consider if this patient may need a one-to-one immediately, PRI medication available, or just additional staff support. Another good intervention is just communication with staff members, the charge nurse, and anyone else who will listen. Here are some useful definitions when trying to understand what violence risk and what violence is on an inpatient psychiatric unit. These definitions are cumulative from my research and the CDC, and they're also included at the beginning of the staff violence risk assessment handout. Here's the top portion of the HCR20. You can see it's asking for the patient's name, date of birth, record number, and gender. Go ahead and make sure that there is a patient label somewhere on the form. It doesn't need to be there on the top. And then we have pre-filled out for you the nature / purpose of the evaluation, which is to assess violence risk on admission. This is the historical set of risk factors that you're going to assess for the patient. Many of these questions and risk factors you will have already assessed in the patient in earlier parts of the adolescent admission process. I am going to go over each risk factor individually, and then you can see that there are 2 columns. There is a presence column and a relevance column, and I'm going to go over that as well. So first, violence. Has the patient engaged in violent behavior? Have they ever threatened violence towards another person or towards objects or animals? Number 2 or 3, because number 2 is skipped, is relationships. Consider if the patient has had experienced problems maintaining healthy, positive social connections, or does the patient lack positive social support? And for adolescents, this is going to include their relationships with parents, their peers, and also any sort of dating type relationship. The 4th is school / employment. Is the patient having problems attending classes or passing their classes? Have they been fired from their jobs, or are they having issues with their job? The 5th is substance use. Has the patient engaged in the use of substances, including drugs, alcohol, cigarettes, etc.? And then how much of substance use has contributed to their current situation? Is it something that their parents are like, oh my gosh, this is why this person's depressed? Or is it something just kind of in the background? That's going to be important to consider later on when you're trying to judge relevance of the risk factors. The 6th is major mental disorder. Does the patient have a history of mental illness? Have they seen an outpatient therapist before or another psychiatric provider? How severe has their mental illness been? Have they only had outpatient services, or have they been to residential treatment before? The major mental disorder category can get a little gray. The authors of the scale do count suicide attempts as an indication that there is a major mental disorder present. It is less clear if self-harm and suicidal ideation count as having a major mental disorder present, especially if the patient comes in and they've never had a psychiatric diagnosis before. What you can do is, if you look over to the number 1 category that says presence, we can see that you can do N, P, or Y. And Y would mean yes, the patient has a mental disorder, and P would mean possibly. And so in terms of marking suicidal ideation or self-harm, you can go ahead and mark that as a possible major mental disorder. Traumatic experiences refers to any of the adverse childhood experiences or any other episode that could be considered traumatic for a child. With children, even a loved pet dying or a grandmother dying can be considered incredibly traumatic. Violent attitudes refers to if a child is expressing things like homicidal ideation, wanting to hurt others, wanting to break or destroy objects, or hurt animals. Treatment supervision or response is seeing if a child has had unsuccessful treatment in the past. For example, we have a lot of children who are admitted from the APHP program, and often these kids were unsuccessful in the APHP program. And in this case, question 10 is asking if a patient had an unsuccessful treatment history. If they had a successful treatment history in terms of engaging in therapy, you would mark N for no. And if they were unsuccessful with treatment in the past, you would mark yes. And if you weren't sure, or it was like maybe a little of this and maybe a little of that, you would mark P for possibly. Other historical considerations that you may choose to mark as present or possibly present would be things like if the child has known cognitive delays, a low IQ, or another type of developmental disorder. Another thing that would go under here is if they have a known history of exhibiting cluster B traits, or other high-risk behaviors like setting fires or hurting animals. And then anything else that you think has happened in their past historically that may contribute to them being a violence risk. This is the clinical risk factors part, and it's referring to if the patient has had recent problems with the following things. And by recent, the authors mean in the past 1 to 3 months, and also currently in the present moment. So the first question is insight. Has the patient verbalized or behaved in a way that demonstrates they do not understand the severity of their unsafe behavior or the severity of their mental illness? Do they understand why they're being admitted? That's a good test for insight. The second one is violent ideation or intent. Are they currently having thoughts about hurting others or hurting objects? 3, symptoms of major mental disorder. On your assessment or in the past 3 months, have they had symptoms of things like depression or anxiety or PTSD or mania? The fourth is instability. You can consider this for adolescents in terms of have they had a history in the past 3 months or currently are they being really impulsive or emotionally labile, going from one mood to another really intense opposite mood? Is it known that they have unpredictable behavior? And 5, in terms of treatment supervision or response, this is referring to if they've had negative response to treatment. So are they willing to engage in treatment? Have they demonstrated that they're engaging in treatment? Are they guarded or lying? These would all be things, or are they not going to their therapy appointment? If the patient is not engaging in treatment, that would mean that yes, this risk factor is present. And if they are engaging in treatment, it would be no, this risk factor is not present. Other considerations. Is the patient accepting of being in the hospital? Are they experiencing really intense anxiety or anger about being admitted? Are they blaming others? Are they able to listen to staff directions and cooperate so far? The last section here is risk management. And the best way to think about this, you can see there that it says future problems with. But consider how during this hospitalization or in the next year, how this patient could have problems with the following things. And it's worth considering because these are things that may influence someone's anxieties, insecurities, or trigger them to experience a loss of control if there's changes. For example, do you think it's possible that this person may refuse to cooperate with treatment? If you think this person may have future problems or problems on the unit with cooperating with treatment, you can mark yes. And if not, you can do no or possibly. Living situation. Is this person refusing to return home? Often kids say, I'm never going to live with my parents again, or I never want to talk to my mom again. So that may mean there's a problem with their living situation. Or in contrast, kids are often worried that they may not be able to go home and instead will be sent away. So both of those things would be a positive yes for future problems with living situation. Or the other thing to consider with living situation is if they're having chronic conflict, or if there's some sort of abuse or some sort of dynamic in the home like a sibling or stepfather, which the patient severely dislikes and is contributing to their stress. That would be another reason to mark yes for living situation. In terms of personal support, does this person have individuals in their life that can support their mental health while they're in the hospital? Do they have people like healthy adults they can call and talk to on the phone, like grandparents or an aunt? And do they have positive adult support for when they return home? Or are they in constant conflict with their parents and it's evident that their parents are unable to provide them healthy mental support? If you can see those things being a problem, or potentially a problem, mark yes or P for potential problem. And also another thing to consider under the personal support category is if you can foresee that relationships with parents, peers, or some sort of dating situation is going to continue to cause a child future problems or problems while they're in the hospital. Treatment or supervision response for the future. I think one thing that's worth knowing is many kids come into the unit with a certain attitude of resistance or anger or anxiety. And what is amazing about the adolescent unit team that is on NBMI is their capacity to build relationships and nurture children and really let them open up. And so, this question you may not be able to predict well. If you can, for some reason, because of their past history or their current behavior, see that this is going to be a difficult pattern to change in terms of their engagement of treatment, you could write yes for probable difficulty or P for possible. And if you really feel confident that this kid is walking in with a good treatment attitude and really wants to engage, you could write no. You can always omit this one as well. I think this one, in terms of the future, is hard to predict. Kids change and kids grow, and there's a lot to be said for what can happen on NBMI and what we can do to nurture kids' capacity to engage in treatment. The fifth question, stress or coping. It's hard to predict if a patient is going to have future problems with that. If you don't know the patient very well, and this is just a basic admission assessment, this is the first time you're seeing the patient, you may have some basics of their history in terms of how well they've coped with stress and their ability to engage in emotional regulation, and you may not. You are welcome to omit this question And the other thing is that the patient's time on NBMI is going to be a huge opportunity for them to really change their future in terms of how well they can cope with stress and just their emotions and the stress of life in general. So feel free to admit this one, but if you know some pretty ingrained behavioral patterns or emotional regulation patterns that you perceive will continue on after this stay on admission, you are welcome to write yes or possibly. Other considerations for this risk management scale section, when you put it in the context of future problems with. Once again, I would go to considering any details about if they have to deal with court or face any more kind of legal or social obligations related to their trauma they've experienced. Another consideration that's extremely relevant is their substance use. Some kids are very adamant that they won't take medications and that marijuana or some other substance is the only thing that's going to help them. And if they come in with that attitude, you may write that down as another consideration if you see it being a future problem. But also, that's something that they can work on while they're on NBMI. In terms of this risk management scale section entirely, it's something that you're just not going to know necessarily many details on admission, but is worth writing down if there's anything in particular that you can see coming up for this kid that could contribute to them being unsafe while on the unit. The most important part about all of this risk assessment is just remembering that you are a detective, and on admission, you are really just getting the tip of the iceberg of a child and family story. No way will it be comprehensive. And violence risk and all the facts of a patient's life come out piece by piece. So just remember that whatever you get on admission is enough to start and go with. And ultimately, you're trying to give yourself a language to identify why and how a patient may be violent. Rating the presence and relevance of the violence risk factors. So this is now an explanation of the two columns, the presence column and the relevance column, and how to go through rating each risk factor. When you first go through the risk factors, you are going to evaluate if the risk factor is present, possibly present or not, or omit. On admission, you're not going to know all the risk factors that are present because you just don't have all the clues. And the aim is to, once again, just do your best and move forward with what is known. And the second dynamic is relevance. How relevant is the risk factor to the patient being violent? And the best way to think about this is in terms of their current admission, because that's why the risk assessment is being done, and in the context of all the clues that you know. Relevance is an opportunity to use your clinical judgment and see what the context of the individual patient in front of you is really saying. For example, the big one that comes to mind is substance use. Is the child incredibly distressed that they will no longer have access to marijuana or cigarettes? Are they extremely distressed about their relationship with their parents in terms of either being away from them or being sent to the unit because of their parents? Both of those things could be reasons the violence risk factors are more relevant. Because they're going to be things that contribute to the child's anger and anxiety. The relevance rating section is an opportunity for you to reflect on the risk factors and consider how they might contribute to a patient being violent. And, even if you don't know for sure, because we cannot know for sure, and especially on admission, we are going to have a limited sense of information and confidence about who this patient is, it gives you a starting point to start reflecting on violence prevention and violence risk for this patient and what that might look like. All right, so here is the last section of the HCR 20 where you can take your assessment findings and then the relevance of the assessment findings and take the individual context of the patient and your experience as a clinician to determine how this person is a risk. What does it mean for a person to be a risk for violence or physical harm? When you make the decision that someone is a risk, what you're saying is that there is some level of probability that this person may engage in this type of behavior. You're trying to make an educated guess in order to better mitigate and prevent a circumstance from happening. When determining a person's future violence / case prioritization, in terms of if it's low, moderate, or high, consider what are the chances that if given the right triggers, may this patient choose to act in a way that's violent, either towards themselves or towards others. Often patients are not acting violent out of context. There's reasons a person's acting violent. And consider what may make, if there's anything that may make this person act violent. And if you can identify things from your assessment that could contribute to a person being violent in some way while they're on the unit, you can mark their future violence case prioritization as either moderate or high. If you feel that there's no probable, most likely no way that this person is going to be violent, even if they have their triggers present for anxiety, then you can go ahead and mark low. You can define serious physical harm as judging if this person is at risk for acting in a way that's going to seriously harm themselves or others. Our original definition we're working with for violence is violence towards oneself, others, and objects. So this means if you think that this person may seriously harm themselves or others, you can mark it as moderate or high, depending on how great you think that risk is. And if you feel like there's no risk of them hurting themselves or others in a serious way, you can mark low. Once you have completed the violence risk assessment, it should go into the patient's chart. Additionally, you should include significant findings in your nurse admission note. And third, communicate any safety or violence risks that you see, especially if they feel imminent. Include them in your nursing reports, and also let the charge nurse know. The violence risk assessment will then be reviewed during daily treatment team rounding so that the provider, and social worker, and other members of the treatment team can make best decisions on how to help this patient.